Hi, I'm Mary Dillhoff. I'm an associate professor of surgery at Ohio State University. I'd like to thank the organizers and the moderators for allowing me to talk today, and especially all their extra work in organizing this virtual conference so that we can continue to learn from each other. I realize what a big effort this is, so we really do appreciate that. I'm going to talk about minimally invasive pancreatic duodenectomy today. More on the as far as the program building and early outcomes. There'll be another technical talk in the session, and so we'll leave a lot of the technical details for that talk. I have been a proctor for Intuitive, and that's my disclosure. So we'll break this down into the current evidence, which there is not a ton, but we'll talk about it. Then program building and training and what it takes to really get a program up and off the ground. A little bit of technical, and then we'll talk about our early outcomes when we started. So there's guidelines from the Miami International Consensus, and that was done before the AHPBA in 2019. There's also the International Consensus Statement on Robotic Pancreas Surgery. So there's really two major guidelines for this. It always makes you question the data that's out there when there's as many consensuses as there nearly is of the actual randomized studies. And so it really goes to show you that we don't have good level 1 evidence at this point to help guide us. And so this is where it gets really important for us to do these things safely and to really examine our outcomes and publish them. So what do we know? So there's two randomized trials. There's the PAGILAP and the PLOT study. This is the PAGILAP. The PLOT had similar results, and this was published in 2018. It was a randomized study, 34 patients in the lap group and 32 in the open group, with the primary endpoint of length of stay. There was a conversion rate of 23.5%. As expected in many minimally invasive trials, there was a decreased length of stay from down to 13.5 from 17, less grade 3 complications, and an increased quality of life, with the offset of having a longer operative time, 486 minutes versus 365 minutes. More recently, the Leopard 2 trial, also randomized patient blinded study, 50 in the lap group and 49 in the open group. And their primary endpoint was safety and time to functional recovery. This trial was stopped early, unfortunately, due to complications of death in 5 of the patients, so 10% in the lap group versus 1 death in the open group, so 2%. This was not statistically significant, but this obviously you can see in the numbers differed enough that this was stopped early by the DSMB. Things that were not statistically different. So the time to functional recovery was similar, the complication rate was similar, and the grade B and C fistulas were similar. So with the data as it is, it's mixed, obviously. All of this data wasn't out when we decided to undertake our education and start our program. However, with what we know now, I think it is really important for all of us to be thoughtful and purposeful in our training and ensuring that we start these programs in a safe way for our patients. So at Ohio State, we had a really long history of robotic surgery at our institution. This paper was presented by our colleagues, Dr. Narula and Makami and Melvin, did actually a hybrid robotic and laparoscopic Whipple back in 2005. So they did the resection laparoscopic, and then they docked the robot for the reconstruction. But this they had stopped completely, and this program didn't last in perpetuity. And by the time we got started again, it was 2017 when we started. And so we had 2 experienced surgeons that were experienced in robotics, but not in Whipples. And so we really wanted to go back and really start our education new and kind of go back to school. And so here's what we thought were important in starting a program. And so most of us would agree that do a fair amount of minimally invasive surgery, that before doing these complicated procedures, you should have an experienced team. And you should have good outcomes with open Whipples at your institution and with high volume surgeons. You need a lot of resources from your institution. So having your institution to back up these programs is really crucial to your having a long lasting program. So you need extra OR time, you need the robot time, all the staff that's involved needs to be dedicated. From the surgeon's perspective, you might have two surgeons doing an operation that takes longer when you both could, be doing other procedures quicker. So support from that perspective, from RVUs and such, if that's how your compensation is calculated, all needs to be accounted for in these programs. And then you need commitment from your team. And I think a really important piece is being able to get through your learning curve in a quick enough way that you don't get kind of every time it's a new thing and it's complicated every time. You really need to get through it. So this is a routine procedure and everybody's not all excited every time they see a robot Whipple on the schedule. So whether you have enough volume yourself or between two of you have enough volume, or all of your partners are going to shuffle volume towards the program, I think that's an important thing to think about and address up front. So here's us, here's me back in school, and that's our lab there. We have a simulator that's off in its own room, so we can use it at our will. And we really put times on our calendar and went and practiced just as if we were going back to school. So we did all the simulators drills again. We ordered biotissue and practiced all the anastomoses. And this was with the help of Dr. Hogue and Zarakat and Zay at Pittsburgh. So we would do the biotissue anastomoses, we would record them. We did skills assessment by sending those recordings to Pittsburgh and letting them grade us and assess our skills. So we knew that our skills, we knew that we were capable of it by the time we went and did our first operation. We did case observations. We did this at two different institutions. So we went and saw Dr. Martini, and we also went and saw Pittsburgh's group. And this also, I think this was really helpful seeing two different surgeons do it. I think every time I watch a surgeon operate, I learn some little nuance that I think is pretty cool. And so I think going and watching a surgeon, even when I go proctor, I still learn from people. And so I think this is a really important piece of this. So we really took what we liked from both of these and kind of meld them into our robotic Whipple. We then did a cadaver lab with Pittsburgh's group and had them proctor us. So we had experienced surgeons proctor our cadaver lab. As far as the team goes, who else is all on this team? So we had this same team for all the operations at the beginning. So we didn't have to start thinking about, retraining the scrub tech and, equipment and what we needed, or the circulating nurse or the first robotic first assistant. We really got a dedicated team for all these procedures. And this was really helpful and just ensuring all the equipment's there, everything's routine and standard, and we were not stressed out by those things in those early days. So same scrub techs, we have robotic first assistants who are very skilled, which is helpful. We performed this with two attending surgeons and the circulating nurse. We we treated patient selection a little differently than what you'll hear a lot of others do. You'll hear over and over again that patient selection is really important for your success. And it is, I totally agree with that. But to counter that, I think it's also important to really get through the learning curve quick. And it's not just the surgeon's learning curve, it's everybody else in the room. So it's getting all the equipment ready and having everything else just run smoothly. And so for us, I wanted to make sure we were scheduling them frequently enough that no one was excited when they saw this on the schedule. And so we did this by being safe, but a little less particular than some might. So we did not do anybody that had suspected vascular involvement or had multiple previous operations. So those were our real only exclusions at the beginning. Here's our port placement and positioning. Again, we won't go into lots of technical details because this is going to be addressed. 4 robotic ports across the mid-abdomen. We use an air seal in the right lower quadrant and a 12 millimeter assistant port in the left lower quadrant. That's what we extend to take out the specimen. There's a liver retractor here on this one. We've been using this less often and using just retracting up on the umbilical ligament on more recent cases. Here's our just setup, and I just show you this because I set all of our robotic cases up similarly so that, again, it's all to help the team do this and be routine. So all the cases are done in a split leg position like this, so an assistant can stand between the legs comfortably. And then this makes it easy doing any of the procedures. We do the distal pancs in the same position so that everything's just the same every time they go to set it up. From a technical aspect, and this is total credit to Dr. Hoag and her teaching and really separating this down into little chunks that are teachable and doable. So mobilization, the lesser sac coker, transect the jejunum in the stomach, the portal dissection, the uncinate and retroperitoneal dissection, the gallbladder, and then the reconstruction. And this was kind of important little breaks for us. So at the beginning, we learned from the Pittsburgh team the term robotic fatigue, and we didn't really know what that was when they said it, but we learned what it was very quickly. And at the beginning, when you haven't been on the robot for several hours at a time, you really do get fatigued and tired. And so at the beginning, it was really helpful for us, since we had 2 surgeons, that we would have one surgeon start, and then basically at every one of these steps, we just would switch. And then the next Whipple, we would start opposite, so that our skills were progressing the same and that we got a break from the robot. So the opposite person would go to the bedside. Our early outcomes. And so I think really important for, as you're starting these programs, to really track your early outcomes. There's a lot to be learned that you can change and fix in here. And so I'll show you a few things that we learned as we tracked our outcomes early on. So this was our data at 14 months. And that's what I really want to share with you. We've done nearly 100 now, but this early part is important because this is, can you train enough to do this safely? So 41 Whipples and 2 total pancreatectomies in the first 14 months. We had 10 conversions to open and only 1 emergent. And that was really my litmus test. I didn't want emergent, an excessive amount of emergent conversions. The major complications were similar. There was 1 mortality at 2.3%, and there were 5 grade B and C fistulas, so 12%. When we looked at our times, they dropped rapidly in the first dozen. So you can see they kind of come down very rapidly in that first 12. We propensity score matched a robotic and open cohort. So 30 robotic cases, the first 30 robotic cases, and to 60 open. Matched for age, gender, race, BMI, the indication, so benign or malignant, and the ASA score. The operative time was, of course, longer as expected. The major complications, the grade BC fistula, the delayed gastric emptying and hospital length of stay were all not statistically different. However, the DGE rate, you can see here, it's not statistically significant, but it did trend higher. And early on, I did anecdotally feel like there was more DGE than I had in my open Whipples. And so this led me to go back. I went back and talked to Dr. Hoag and others about just technical aspects about what we could have been doing that might have caused this. And so, and I do think this was probably a technical issue at the beginning. And so this goes to show why it's so important to look at these outcomes, because these are things that you can fix and change. And we did modify some things, and in our more recent groups, this number has come down. The readmission rate was higher, and again, this allowed us to go back and look and say, well, if the complication rate's not statistically higher, why are these readmissions? And again, this number has come down as well from those first 30. From the patient perspective, we all know that this is what they care about so much, and so robotic Whipple on the right versus the open Whipple on the left. And so although we think of this as not as important, there probably is some important things in here, such as decreased hernia rates and such. So what do we learn? I think it really does take a dedicated team to start and maintain a Whipple program. So that's an important piece of it too. I really wanted to make sure that we started a program that kept going and that we didn't do one or two and it was so painful that we never wanted to do it again. Implementing this program can be done safely, and I think that we showed that with the proper training, this can be done. And the education and training up front are important, and they may help reduce or eliminate the learning curve. So again, I just want to thank you for allowing me to talk today. I really appreciate everyone's time. Thank you.